Good morning, everyone. Today I will be presenting on efficacy of adalimumab in non-infectious uveitis. Uveitis accounts for nearly 10 to 25% cases of legal blindness in developing countries. Resistance to conventional therapy, drug-related adverse effects pose a significant barrier to treatment. Biologics have emerged as a useful substitute for treating uveitis. Adalimumab is a fully humanized monoclonal antibody directed against TNF-alpha, thus inhibiting its activity. In July 2016, adalimumab became the first and only FDA-approved biologic after randomized control trial of Visual 1 in 2 study, which was followed by Visual 3 study. However, in a country like India, the use of biologic agents is feared to be more prone to developing infections. We conducted this study to describe the treatment outcomes of adalimumab in non-infectious uveitis. It was a retrospective observational study conducted between 2017 to 2023. Electronic medical records of all non-infectious uveitis patients were treated and the adalimumab were analyzed. We excluded patients with infectious uveitis and who had a follow-up duration of less than 6 months. Adalimumab was indicated in case of inadequate response to immunotherapy, intolerant to immunotherapy, and in some cases of primarily for the disease. The criteria for treatment success was control of inflammation, significant decrease in disease recurrence, vision improvement, and vision stabilization. Appropriate investigations were done whenever possible. Non-response to immunosuppressive was described as deterioration or persistent inflammation for 3 months with the use of immunosuppressive, and a decision to administer adalimumab either as first-line therapy or non-response to immunosuppressive was made after consultation with rheumatologists but primarily at the discretion of ophthalmologists. Appropriate statistical tests were analyzed and p-value of less than 0.05 was taken as statistically significant. To the best of our knowledge, this is one of the largest study in India involving adalimumab treatment with non-infectious uveitis, including 43 eyes of 26 patients with 14 males and 12 females. The mean age of adalimumab treatment was 18 years, and in the mean age of diagnosis of uveitis was 14 years. Anterior uveitis was diagnosed in 11 eyes, intermediate in 5, anterior with intermediate in 12, and pan-uveitis in 11 eyes. The mean duration of follow-up was 19 months in our study. Only 4 patients were there who did not receive prior immunosuppressive therapy. The most common cause etiology was a JIA, around 50%, which was followed by Behçet's, VKH, and the last being Crohn's disease. The course of uveitis in our study was complicated by various complications, including posterior synechic cataract, bend-shaped keratopathy, CNVM, CME. 10 eyes, that is 23% eyes, required some surgical intervention due to the pre-existing complications. Adalimumab monotherapy was considered in only 1 patient. Oral steroids were stopped completely in 12 patients, and oral steroid dose could be reduced to 2.5 milligram per daily in 8 patients. Disease inactivity was achieved in 97% of the eyes at large fridges, which was statistically significant, and disease remission was achieved in 74% of the eyes at 3rd month. Visual acuity improved from 0.45 logMAR units to 0.24, which was statistically significant. Overall, vision improved in 21 eyes. It was maintained in 16 eyes and worsened in 6 eyes, which could be attributed to various ocular complications. Drug was discontinued in only 1 patient due to financial constraint, and relapse was seen in 2 patients. We did not encounter any serious systemic adverse effect in our study. Only 1 patient had raised liver enzyme who was concurrently receiving methotrexate. This is a photograph of one of our patients before and after treatment with adalimumab. The management of non-infectious uveitis is a dynamic field. Effectiveness of adalimumab has been well demonstrated in JIA-associated uveitis by Sycamore and Adjuvite trials. However, accessibility and affordability of biologic therapies in a resource-limited country like India remains a challenge, thereby limiting their use. Likewise, in one of our patient in a series, the treatment could not be continued due to financial constraint, and he had to be shifted to oral methotrexate, following which there was a recurrence. The EULAR consensus considered anti-TNF-alpha as a first-line agent for treatment of Behçet's associated uveitis. In our series, 3 patients with Behçet's uveitis responded well. 1 patient with Crohn's disease and our patient required adalimumab. None of the patient in our study develops any severe complication. And adalimumab, even though it has a low rate of recurrence, relapse can still occur. In our study also, relapse was seen in 2 patients. There was some limitation. Our study had a small sample size. However, ours is a tertiary referral center that offered cases difficult to treat patients who frequently present late in the course of disease, and the mean duration of uveitis from symptom onset was 46 months in our study, and quantification of inflammation was not done. To conclude, adalimumab was found to be effective in the treatment of non-infectious uveitis by achieving disease remission, reduction in recurrence rate, with subsequent improvement in BCVA. The drug is safe and well tolerated, as we did not encounter any systemic infection or adverse reaction to the drug. It has a corticosteroid sparing effect. Thank you.
In how many patients you have started that adalimumab as a first line therapy?
So for 4 patients.
That all the basics one. Okay. Have you tried infliximab in any of the patients who were not responding to the IMT?
No, sir, in this particular group of patient, we did not try infliximab. Most of the patients' response was good.
Okay.
So,
So you haven't included the patients who were on infliximab?
no, sir.
No.
In these patients, they have never received infliximab also, the
Okay.
patients we have included.
So I think you can have a study comparing that infliximab
Infliximab
versus
versus-
adalimumab.
Yes.
Because that infliximab, the chances of recurrence are higher when you give the second injection because of the formation of antibodies against that infliximab. Methotrexate inhibits the production of those antibodies against that infliximab, but I think that adalimumab is really a very promising drug to take care of particularly the pediatric uveitis. And I think yesterday Professor Peter Makulski has presented his experience of that adalimumab in the Australian population. Yesterday only he was having a very nice talk, so I think that it's a very promising drug.
How many patients were still active post adalimumab? What subset?
Sir, the relapse was seen in only one patient, and that patient usually, we had to discontinue adalimumab due to financial constraint. Then we shifted the patient to methotrexate. After that, the patient developed recurrence, but then again we shifted the patient to adalimumab.